IOL exchange, a novel technique. A 43-year-old businessman presented to us with diminution of vision in the left eye. He was diagnosed with posterior subcapsular cataract requiring phacoemulsification with intraocular lens implantation. However, the patient demanded that he wants spectacle freedom post the surgery. Thus, all the necessary pre-operative investigations were performed, namely the IOL Master 700 and the IDREES refraction, which showed that the angle kappa, angle alpha and the total corneal aberrations were all within the normal range. Considering that he is a potential candidate, phacoemulsification with trifocal IOL implantation was planned. A thorough pre-operative counseling was done regarding the patient's expectations post-surgery. Post-operatively, even though he had a vision of 6/6 and N6, he was extremely dissatisfied. According to him, his vision was clear for the distance and near, but he was unhappy with the intermediate vision and the range of this intermediate vision. The post-op IDREES refraction was also insignificant, and the patient was not accepting any glasses for distance or near. The patient was counselled to wait and allow for neuroadaptation, as is advocated for the acceptance of trifocal IOLs. However, even after 6 months, the patient was unhappy and wanted a revision surgery. After explaining about all the possible complications, an IOL exchange with an EDOF lens was planned. Intraoperatively, after the clear corneal incisions were made, generous amount of viscoelastic substance was used to separate the anterior capsular rim, the IOL, and the posterior capsule from each other. Owing to the fact that 6 months had passed post the trifocal IOL implantation, significant epithelial cell migration had occurred, causing dense adhesions around the two haptics. Multiple careful attempts were made to release the haptics from the surrounding fibrosis. It was a Herculean task. However, the knobs of the haptics were particularly adhered to the capsular bag, causing considerable zonular stress. In an ideal situation, the IOL should have freely rotated in the bag in order to prolapse it into the anterior chamber, which was not the case here. As scary as it looks, a last attempt to release the locked haptics was made, but to no avail. Encircled in this video, we can see a fibrosed tunnel surrounding the knob of the haptic. Hence, a decision to cut the optic in half within the bag using a IOL cutting microscissor was made, disengaging the two haptics from each other. Then, intraocular microforceps was used to pull out each haptic from the fibrosed tunnel. And the two halves of the IOL were removed separately. The trifocal IOL was successfully explanted without compromising on the zonular or capsular bag stability. Following this, an extended depth of focus IOL was placed successfully in the bag. Visco wash done and the wounds were hydrated. On post-op day 1, the patient had a spectacle-free vision of 6x6 for distance and N8 for near. He was happy with the intermediate vision, the extended range of vision and its quality. It is well established that superposition of focused and unfocused images can cause visual disturbances post-trifocal IOL implantation, which can be troublesome for patients. When IOL explantation is planned after a delayed period of 3 to 6 months, formation of dense fibrosis around the haptics makes the explantation challenging as the bag and the zonular stability can be compromised. This technique of in-the-bag IOL explantation seems to be a promising one in cases where even after waiting for neuroadaptation, the visual disturbances do not decrease and IOL exchange seems to be the only option. The key takeaways from this technique of delayed in-the-bag IOL explantation are disengaging the two locked haptics to allow for easy explantation of the IOL, and to rotate out the disengaged haptic from the surrounding fibrosed tunnel to maintain the capsular bag and the zonular stability.